Today, I have the honour of speaking to Professor Peter MacMahon, and Peter is consultant radiologist at the Mater Hospital and clinical professor at UCD. And he'll speak to us today about generative AI in the ED, developing tools to predict the future. Welcome, Peter. It's so lovely to have you here today.
Thank you, Patricia, for inviting me on. I'm excited to be here.
Well, we're delighted. And to kick off, please, Peter, could you please give our audience a brief snapshot of your career and how you became interested in AI?
Yeah, so I was a UCD medical student, and then I entered into the radiology training scheme in the Mater Hospital. And after completing that training scheme, I went to Boston and I worked in the Massachusetts General Hospital. And I specialized in two areas. One was emergency radiology. So the imaging of the most sickest people when they present to the hospital after, for example, trauma or stroke and different emergency conditions. And they also did a fellowship in musculoskeletal imaging and intervention. So looking at sports injuries, but also bone tumors and other aspects. So I completed those fellowship training exercises in this Center of Excellence in the United States. And this is like a hospital with 19 MRI scanners, including MRI scanners in the emergency department. A very different environment to the Irish healthcare system and very differently resourced. So I've come back to the Mater Hospital as a consultant, and I started there in about 2012. So I've now been a consultant about 12 years in the Mater Hospital. And I suppose because of my interest in emergency imaging, which is a very kind of time-sensitive area of medicine where we need to make some complex diagnoses very quickly, we've kind of understood that there's an awful lot of data to be processed, and I wonder if computers can be an assist in that process. So it was back in probably 2015 when I first began delving into the role of computers to help us make complex decisions. And one of the first areas I looked at was stroke. Now, we can talk about that later, but stroke consists of an awful lot of complex imaging studies, and that we delved into the rollout of an AI software solution that would help us make decisions for patient care in the emergency department. And that's really, at that time in 2015, is when my interest in the role of AI, the future of AI in healthcare began.
Amazing, amazing. And please, to our audience, please submit questions as you think of them, and then we'll get to them after the first couple of questions. But Peter, that's incredible. And the Mater became the first hospital in Ireland to use AI across its radiology department. So can you tell us where it's used and maybe the example that you talked about there of stroke, maybe tell us a little bit more about that?
Yeah, so we have several different AI vendors and AI software solutions that do different aspects to our care, and that they're running 24/7 all the time. And they look at several different aspects. So one is stroke. So if a patient arrives at the emergency department door with a suspected stroke, so the emergency doctor or the nurse, triage nurse, or other physician nurse decides this patient could be having an acute stroke. So they've lost power on one side of the body, for example, the classic presentation. We need to know what exactly is going on inside the brain. And in particular, you need to differentiate two different conditions. Is there a hemorrhage, so blood in the brain, or is there a blockage to a blood vessel causing a ischemic stroke? So a blood vessel is blocked, and so the brain distal to beyond that blockage is beginning to die. And the two very different conditions that can present the same. So we perform an awful lot of upfront imaging for these patients, and we hope and we try, and we usually are successful getting a patient from the door of the emergency department onto the CT scanner within 10 minutes. And time is brain. So the quicker we can do that, the more brain cells that we can save. So we do an immediate CT essentially for these patients. And within 2 minutes of that scan being performed, the AI will have given us a result. And that result is provided to the emergency physician, the radiologist at the time. And it will analyze for several different things. It will look for blood, and it will in particular look for very subtle bits of blood that are easy for us to miss. This is like a really pressurized environment. There's an awful lot of images, can often be about 2,000 images to look at. So we have to quickly go through all these images, try to make an accurate diagnosis, an accurate prognosis for that patient, and then the patient's management will usually be affected. So we use the AI to help us make those decisions. It's never on autopilot. So it's always a radiologist, a human in the loop, double checking and using the AI as a tool to help us make better decisions, but it is not the decision maker. So in stroke, we use that to look for blood. We help it to look for blood vessel blockage. It also looks at the brain and the way it's perfused. So we can try to find where the area of the brain that's being at risk of dying, and then try to make a prognosis on that finding. So for example, if a large part of the brain is being underperfused, so it's not getting enough blood, we can make a decision about whether they should be transferred to a different hospital for treatment, for example, Beaumont, and they can try to fish out a bit of clot from a blood vessel. And we use all the tools which are done straight away after the patient arrives to help us make that decision. We can do it manually. So if the AI, for some reason, was turned off, we could do it, but we'd actually struggle. I think we kind of, in somewhat, are reliant on it to help us make these complex decisions in a timely manner. So we slow us an awful lot down to have no AI analysis. So we have those tools for stroke, but we also look at trauma patients. So if you come in and have a spinal injury, the AI will immediately look at the scan and give us flag the little areas in the bone where it thinks may be fractured, and often is correct and often finds very small fractures that we may miss, and so is useful. And then the last thing it kind of looks for is clots. So we have a tool that looks at all our CT scans. So not just patients who are suspected of having a clot, but every patient. And so we have found by running the software on every patient all the time that we have a 100% increased rate of detection of clots. And that's because the AI is finding clots we missed. So patients are having clots to their lungs. For example, classically would be a cancer patient who are prone to coagulation and clotting. They are having their scans for staging, for their treatment and different things. And the AI will flag a scan and say, actually, this patient has a clot in their lung, and we would have missed it, easily would have missed it. So it's always analyzing our scans and is definitely showing us stuff we would have missed.
That's just unbelievably incredible that this is state of the art now and that you have that operational. And I know you spearheaded that. So huge congratulations to you, Peter. And I'm sure that's going to spark many, many questions with our audience. But I suppose just before we finish chatting, I want to ask you about, and it's just something you mentioned about what was standard in the US in emergency care was an MRI machine. So I know that's not standard where you are. So, and it's not standard across Ireland. So what do you think in terms of future possibilities for, so you're already accelerating care, you've said that, but what about accelerating it further? Any thoughts around that?
So, I mean, there's an idea of generative AI, so generating new data, new images using artificial intelligence. So we've been thinking about that within our emergency department. And one of those things that we have a lack of access to is MRI. So MRI scans are scans, it's a very expensive scanner. It's usually about €1.5 to €2 million to get it. It's very expensive to staff it. And it's very difficult to fit it into these very busy and relatively small emergency departments on our end. So typically, or no emergency department in Ireland has an MRI scanner in the department, even though that wouldn't be that uncommon in other places around the world. So a lot of patients who present to the emergency department really do need an MRI. So what often happens, for example, if you present to a hospital who does not have access to an MRI scanner, especially in the middle of the night, you may need to be transferred across the country for your MRI scanner. That's particularly true for spinal conditions. So the Mater Hospital is obviously a national spinal injuries unit, and we have 24/7 spinal care. So we can accept patients from other hospitals and we provide an MRI scan for them in the middle of the night. And if that scan is negative, they will go all the way back to wherever they came from. That may be Galway or Letterkenny and other places. And it seems that it's a huge amount of resource just to do that transfer and also to provide that 24/7 service in the Mater. So our idea was, well, could you use generative AI to predict the MRI scan? So you have another data source. So it's CT. Every emergency department in the country has a CT scanner 24/7. So the idea is there enough data within a CT scan to give you an accurate prediction of what the MRI will look like if we do get it? And the idea is maybe not to completely avoid the need to MRI, but allow some kind of de-escalation of a scenario where you're pretty confident there's nothing serious going on. The patient does not need to be transferred in the middle of the night. We can wait for the MRI in the morning. So what we've done is we've trained a model with CT scans. So every patient who came to the emergency department with suspected spinal condition, acute spinal condition, we got them a CT scan and they consented for that. And they also got their MRI scan. So we have this data set of a large number of patients who have CT and an MRI. We feed that data into the model and we tell the model to try to predict the MRI. And so we weren't sure if this would work and we didn't have that many patients. But for whatever reason, there is enough data in a CT scan to make an accurate prediction of the future MRI. So when we now give it a CT it's never seen before, it will say, well, based on the training data, we can predict an MRI that will look like this. And this is what the patient has if we did an MRI in the future. And so this seems to work quite well. And in the very specific condition we've looked at is called Cauda-Equina syndrome, where you can have typically it's a large disc herniation, so a large bulging disc that comes out, compresses the nerves in your back, and then you have a very serious condition that isn't diagnosed, can lead to kind of permanent neurological disability. So the idea is you do a CT, which it takes 2 minutes and is available everywhere. You get an MRI straight away predicted, and that can give you, in our opinion, our experience so far, high reassurance that there's nothing going on or there is something very severe going on. And if there's nothing going on, I would be my prediction if we finally do some proper study on it, that you can avoid a transfer in the middle of the night and that you could wait or maybe not need the MRI at all. And if it predicts a very severe scenario, you'd immediately transfer the patient to the spinal service. So that's one of the areas where we're using or researching the area using generative AI to predict a future scan.
There's so many questions coming in for you, Peter, and where I could chat to you all day, and I'm sure our audience could listen to you all day. The fact that you're using Gen AI is just amazing. So congratulations, and that's just an incredible use case that you've described. I'm just looking through the questions here. So you're obviously you're involved in all this training, set. You're getting the data. So the reliance on the quality of the data is something I suppose some of our audience are asking around, and this idea of what you put in, you get out. So maybe you can talk about that from relation to radiology data and what you've found.
Yeah, so it really is one of the interesting things of doing AI research is that it keeps coming back not to the model they use, the computer science programming aspect of the model they use to make the prediction. It really comes back to a huge part of the problem is the data. And is the data good data? So is it the correct patient population? Is it a kind of a broad enough representation of that population that you're predicting to see? And is the data being annotated? So for medical imaging data, we want to tell the model what to look for. And so you need an expert essentially involved very closely with the programmer or the data managers to say, well, this is relevant data, this isn't relevant data. So in the Mater Hospital, we have a relatively unique scenario where we have a AI research programmer based in the Mater called Paul Banahan. And he has a master's in artificial intelligence from DCU, and he's an expert Python programmer and programs in artificial intelligence. And he is an office very close to me. And so he will get the data, he will work with the data, and then he will maybe try to develop a model with it, and then maybe hit some roadblocks. And then he'll come around to my office and say, this is happening, I don't understand what's happening. And then usually it's the data. And the data is scans. So in radiology, it's all about medical imaging. And I suppose if there's anything I'm an expert in, it would be medical imaging data. So I can look at the scan and I can say, okay, I can understand what's happening here. I can understand what you're trying to do. We need to change the data. We need to get more data. We need to do it annotated differently. And I think that kind of symbiotic relationship works really well. You have the data manager, the programmer working very closely with, say, a domain expert, such as a clinician in healthcare. And once they're working kind of together at the very start, working with the data before they even train the model, then you can get really good output because the input will make the output. If the input isn't good, the output won't be good. And it's very, very key. And it's very obvious that to all AI, it's about data. It's all about data.
It's just music to my ears, music I hope to the audience ears as well. Thanks, Peter. And there's another question around, I suppose, the subspeciality around radiology. And so if I get this right, just to synopsize, where would the application of AI be more impactful compared to others in your subspecialty? Maybe you've already answered that by comparing comparison of CT data and mobilization into MRI. But it says, for instance, would it be, and I don't know what this means, but would it be in the diagnosis of MSK injuries? I don't know what that is, or cardiovascular emergencies. Maybe you could have very specialized.
So MSK, musculoskeletal. So, if
Okay.
you deploy the AI in different areas of radiology, so musculoskeletal conditions or stroke or other areas, cardiovascular disease and different things, which would be more impactful. I mean, it's very hard to know. The reality is that, I mean, the vast majority of people having imaging is basic X-rays. So GP, referring for a patient will often get a chest X-ray. If it's very, very common for people to have extremity X-rays, or X-rays of your ankle, your wrist, and different things. So you could argue that even though they aren't usually life and death situations when you're getting an X-ray, it is such a common scenario and it's such a common test that if you deployed AI on that modality, you'll have a very bigger impact. And it's so we very recently done that in terms of musculoskeletal X-ray. So all our X-rays now, so if you come in, you think you've maybe broken your ankle, but it's very, very swollen, you can't put weight on it. You come into the emergency department in the Mater, you'll have your X-ray, and then again, within 2 minutes, the AI result will pop up. And it'll be available immediately to the physician or the nurse practitioner. If it's 2 in the morning or 4 in the morning, midday, it's always there. And it will give you quite a relatively definitive negative for fracture, positive for fracture. It does have a kind of a doubt section where it's not super certain, but it'll just flag this little spot. And we've only just deployed it now. And it's just being kind of available on the front line, and not just radiologists. But when we use CT, the radiologists are very much the gatekeeper of the result of AI. But when we use X-rays and we provide the AI results, we're now allowing the person in the front line to get the AI result without a radiologist in between. So it's kind of a new territory, I think, for us. Yeah. But you can imagine we do at least 300 X-rays of bones per week in the Mater. So like 300 AI results every week coming out of this system. So it could potentially be quite impactful that way.
And a lot of data. I like it. And just because we're running out of time, but I really want to ask you this. So there's a couple of questions coming in around, are all doctors required to be trained in AI solutions and, the use of AI? And then, there was a really interesting paper in Nature Medicine in March that kind of gave where sometimes the user learns from the AI, but they may actually make inaccurate, the AI makes some kind of inaccurate prediction, and that actually negatively influences the decision that the clinician will make. So talk about that. Talk about, all that, this being the norm, wrong decisions, bad data, all of the rest. But what's your thoughts around this, Peter? Because it's pretty fundamental.
Yes, and it's a common question of, okay, so radiologists are probably leading the way in terms of the rollout of AI in the actual clinical environment. And should radiologists be trained in the fundamentals of how AI work? And I think it's probably true to a certain degree that, say, radiologists need to get some kind of basic training in what the terminology means and what are the kind of pros and cons of different AI models and how they work and the importance of the data. But I think it's probably much more important that we get trained on the risks of deploying AI and the fundamental risk of being a human, in that we trust machines. For some reason, we trust machines. And it's very clear to us now in the Mater Hospital of the idea of automation bias. So the idea that if you get a result generated by the AI vendor that comes up with a very nice, very clear, very definitive result of negative, no pathology identified, it's the gut reaction of the human to go, okay, well, that's the result. And isn't that fantastic? And not to actually immediately doubt it. And you really have to force yourself to go, okay, it's saying negative, but I'm going to double check it just the same I always did. But that is just not the natural human reaction. A natural human reaction to go, well, actually, that allows me now to speed up reading this. I can fly through this case. I'm just going to quickly scroll through all these images and go, yeah, I don't see anything either. Great, next case. And you will miss things because the AI misses things. It has, it is not error-free and never will be. It just never will be error-free. Just like humans are never error-free. But if we had 2 humans reading the scan, it'd be better than 1. So an AI plus a human is better than a human on its own. But we definitely have had cases where the AI has missed something, the human has missed something, and you show it to the human, the radiologist, and the radiologist says, I can't believe I missed that. I would never miss that. And it's almost certainly because there was an automation bias. There was this, okay, I'm going to lean on the AI now. And that's a big part, I think, for radiologists, and I'm sure it'll be for other healthcare specialists, is learning about using AI in clinical practice is not trusting it completely. And that you just have to double check. It will have blind spots and it will make funny errors. You just don't understand how it made that error. You'll find this tiny little bit of blood. You're like, amazing pickup. And then the next case, very, very similar periods, it won't pick it up. And it may be that 1 out of 100 cases it'll do that, but it'd be very hard to explain. But the human probably wouldn't have missed it, but you might get biased by the result of the AI. So I think that's the more important aspect to training for radiologists when using AI.
Amazing. Thank you, Peter, because it's a tool. It
Yes.
is a tool. It's a tool to augment human intelligence. And it certainly is never going to replace clinicians. If from anything you're saying, that's what I'm hearing. And unfortunately, we are completely out of time. So apologies to those of you whose questions I didn't get to, but I really want to take this opportunity to say a massive thank you to Peter today for the most fascinating discussion. Thank you so much, Peter.
Thank you, Patricia.
And thank you to everyone else for joining in. That was an amazing presentation. And please do join us again for the next HIT series. And thank you so much. Take care.
Thank you, Patricia.
Thanks, Peter. Thanks so much.